Yeah, good evening, everyone.
With these few
Thank you, sir, and thank you, Dr. Govind. I think first of all, I'd like to congratulate both of you for taking such an excellent initiative. This is a great academic exercise, especially in these difficult periods, and it is going to be of an immense benefit to all the students as well as the practitioners. And I also welcome my close friend Sudipto, who has kindly consented to moderate this session. So we're going to talk about how to approach a patient with an SOL in pancreas. And this was a very great quote which I found in Lancet in 1980s, which says that for most diagnosis, all that is needed is an ounce of knowledge, an ounce of intelligence, and a pound of thoroughness. So hence, it's very important to have a systematic and a thorough approach to establish a diagnosis for any disease, and more aptly for a pancreatic space occupying lesion. Diagnosis and clinical workup of pancreatic SOL is a challenging problem, but patient's history, lab parameters, CT findings, and EUS are the important cornerstones for establishing a diagnosis in space occupying lesion. It's very important for us to have an appropriate diagnostic strategy for correct diagnosis so that we don't either over or under treat the patient. So when we look at a management strategy for a pancreatic SOL, it basically involves 3 steps. The first step is to establish a diagnosis, whether the lesion is benign or malignant or a potentially malignant lesion. Once we have done that, the second step is staging of a malignant space occupying lesion, whether it's resectable or unresectable. And once we have decided that, we go on finally on to treatment, which can be either surgery, chemo, radiation, or neoadjuvant. In this talk, for the lack of time, I'm only going to talk about the diagnostic approach of differentiating between benign, malignant, and potentially malignant lesion. So what's the first step? Whenever a patient comes to you with a space occupying lesion, obviously he'll be carrying an imaging modality. So first thing is to find out whether it's a solid, mixed, or a cystic space occupying lesion, because the diagnostic approach for both these broad categories of space occupying lesion is different. And on a CT scan, it is usually easier to differentiate between an ill-defined hypodense solid mass lesion and a well-defined cystic lesion. But then this is not always true, and sometimes you should be prepared for surprises. Like for example, here in this patient, you find a well-defined cystic lesion on a CT scan, but when you do an endoscopic ultrasound, you find that it's actually not a cystic lesion, it's a solid lesion. But then if you carefully go back and again look at the CT scan, you find that there are some hyperdense areas. So probably it's a mixed solid cystic lesion on a CT scan. But whenever you encounter such surprises, you should change your diagnostic strategy accordingly. So let's first talk about a solid or a mixed solid cystic SOL, because the approach is similar. And whenever you see such a patient, the pancreatic adenocarcinoma is always the first differential suspicion or a diagnosis. But then it's not the only diagnosis. There is a long list of other malignant and benign diseases, which you probably don't have to remember. But in common clinical practice, apart from adenocarcinoma, we'll see neuroendocrine tumors, inflammatory mass, autoimmune pancreatitis, lymphoma, metastasis to pancreas, solid pseudopapillary epithelial neoplasia, and pancreatic tuberculosis. So more or less, we will be concentrating on these diseases, and we'll find in our daily practice one of these as cause of a solid SOL in pancreas. So what do we do? Patients, as I have already told you, they will come with some cross-sectional imaging to you. So you need to answer some questions. First is, do you need to do any blood investigation which can help in differential diagnosis? The imaging which the patient has done, has it been done properly? Is it appropriate? If it has been done properly, do you want to do any further imaging? And is there any role for tissue diagnosis? If yes, then which route has to be followed to establish a diagnosis? So these are the broad questions which you need to answer. And this all exercises to differentiate between a benign and malignant SOL. And most of the time it will revolve around adenocarcinoma versus an inflammatory mass versus an autoimmune pancreatitis versus other rare malignant SOL. So this is how you're going to approach the patient with an SOL. So let's look at blood investigations. First of all, you should understand that there is no blood marker which has a high accuracy for differential diagnosis. So hence you just cannot rely on blood investigations. CA19-9 is a marker which is commonly done, and it has got a fairly good sensitivity and specificity for pancreatic cancer. But then it cannot be used for a differential diagnosis because of certain limitations. First and foremost, you can have false negatives in lesions which are less than 2 centimeter, and 5 to 10% of population lack the Lewis antigen, which is required for its expression. So these patients will have false negativity despite having an adenocarcinoma. And we all know that in patients with autoimmune pancreatitis, inflammatory masses, as well as in obstructive jaundice, the CA19-9 is elevated. Hence, it has got a very poor discriminating value for differential diagnosis. The other two markers are, one is IgG4. Again, it has got a very low discriminating value because apart from being elevated in type 1 autoimmune pancreatitis, it is elevated in 10 to 20% of pancreatic cancer, and then a subset of AIP, that is type 2. In almost 80 to 90% of these patients, IgG4 levels will be normal. And then there are other set of markers like chromogranin and neuron-specific enolase, which are markers for neuroendocrine tumor. Again, they suffer from the same problem. They have a low discriminating value as well as sensitivity. So they are done only when your imaging is suspecting it to be a neuroendocrine tumor. And then we all are aware that they can have a falsely elevated values in patients who are taking proton pump inhibitors and renal insufficiency. So broadly, we don't have any blood marker which can help in differential diagnosis. So we have to rely on imaging, and contrast enhanced CT scan of the abdomen plays a key role in evaluation of pancreatic solid SOLs. And once we see a CT scan, we need to ask ourselves two questions. Is the mass clearly visible on CT, or we just have indirect signs like a dilated main pancreatic duct or a dilated bile duct? And then if the mass is visible, has the enhancement pattern properly studied? So in other words, is a proper CT with a pancreas protocol done? What do you mean by pancreas protocol? I like to spend some time here. It's a multi-detector CT with a 3D reconstruction. You should have a thin slice thickness, which should preferably be less than 5 millimeter. And importantly, 4 phases should have been studied. First, unenhanced, then an early arterial phase, which is about 20 seconds after the contrast injection, a pancreatic or a late arterial phase, which is at 45 seconds when there is a maximum enhancement of the pancreas. And finally, we take a cut at 70 to 80 seconds, which is a portal venous phase for looking at the liver and distant metastasis. And it is also important that when you're doing a CT with pancreas protocol, you should have administered a negative oral contrast, that is water, because if you give positive oral contrast, it will create artifacts for 3-dimensional post-processing, which is an important protocol for an MDCT for pancreas. And also importantly, all these societies advocate a chest imaging as a part of CT protocol to look for metastasis in lung or mediastinum. Why these 4 phases are important? Because when you do a first non-contrast CT, you will have an evaluation of baseline enhancement of the pancreas, and you can look at the calcifications or stones in the pancreas, which can be missed if you give contrast. In early arterial phase, you will look at the major arteries, which are very important for looking at the invasion, vascular invasion by the tumor. And late arterial phase or the pancreatic parenchymal phase is the most important for evaluating the pancreatic SOL. In case of pancreatic cancers, they will be hypovascular or hypoenhancing, whereas the neuroendocrine tumors will be hypervascular or hyperenhancing. And then finally, we look at the liver at the venous phase to look for the hypodense metastasis. So this is how we do a CT with a pancreas protocol for solid SOLs. And as I've already highlighted, adenocarcinomas are hypovascular and poorly enhancing in the pancreatic parenchymal phase. But the problem is most of the other differentials like autoimmune pancreatitis, inflammatory mass, tuberculosis in our country have similar appearances on enhancement. And hence only the neuroendocrines, which are hypovascular and enhanced avidly, would be able to be differentiated on a CT scan. So to sum up, a properly done MDCT will help us in localizing the mass, differentiate neuroendocrine tumors versus the rest so that we can manage our algorithm accordingly. And then it will help us in detecting metastasis as well as vascular invasion. So now if we have a proper CT, is there role for any further cross-sectional imaging? Do we need to do an MRI? We know that MRI can detect primary tumors as well as regional and distant metastasis as good as CT, but when the studies have compared CT and MRI, a properly done MDCT has no clear advantage over CT, except in few situations. For example, if you have done a CT, you don't clearly see a mass. MR has got a better spatial resolution, so small lesions can be better picked up on a contrast-enhanced MR. And many times we find that there is a mildly dilated pancreatic duct or a mildly dilated CBD, and then there is diffusely enlarged pancreatic head. In such situations, a MR would be useful, and you can do a MR after doing a CT scan. But otherwise, in rest all situations of pancreatic space occupying lesions, MR has no added advantage over a CT scan. Then what about FDG PET CT, which is quite commonly done here and there? First of all, you have to understand that FDG PET CT has a lower spatial resolution than an MDCT. So it has got a poor sensitivity for detecting pancreatic mass as well as vascular invasion. And then we all know that false positive PET can happen in inflammatory conditions, and false negatives can occur in necrotic tumors or mucinous tumors or tumors which are less than 1 centimeter. Does it impact management? There are studies which have looked at the impact of PET-CT on management. I could just come across 2 studies which had documented detection of unsuspected distant metastasis in 16 and 13% only patients where the management changed. So most of the guidelines would not recommend routine use of PET-CT over an MDCT. Hence, as PET-CT does not give any added advantage, it is usually not advocated for patients who have undergone a proper MDCT. Then if we have done a proper CT, we have evaluated the mass, then what next? Now, if the CT has detected metastasis, the algorithm is a little easier. You just do an image-guided tissue acquisition, confirmation of the diagnosis, followed by the specific treatment. But if there is no metastasis, what to do? Then there are 2 approaches. One is to do an endoscopic ultrasound and do a tissue acquisition, or second approach is to do an upfront surgery. So why EUS? We all know that it's the most sensitive modality for evaluating pancreas as well as pancreatic masses. Small masses, even less than 1 centimeter, can be seen clearly on EUS. The diagnostic accuracy is increased by fine needle aspiration and now with fine needle biopsy. There is no risk of needle seeding. And then you complement the staging information by evaluating involvement of mesenteric vessels where it is better than MDCT, small liver metastasis, especially in the left lobe, and nodal or peritoneal involvement where it stands ahead of all other modalities. And then suppose if you want to do a preoperative staging, both EUS and ERCP preoperative stenting, both can be done in the same sitting. And for an unresectable cancer, celiac plexus neurolysis can be also done in the same sitting. So these all are the advantages of doing an EUS, but then it's a debatable topic whether to do a tissue diagnosis before surgery in a resectable mass. The proponents of acquiring a tissue will say that small percentage of patients have a benign disease like tuberculosis, especially in our country. It can detect malignant lesions that don't need surgery, like lymphoma for metastasis. Biopsy is safe and cost-effective. Studies have shown that it improves our staging capability, and more importantly, it gives a psychological and tactical benefit to both patient and surgeon if malignancy is confirmed preoperatively. But then opponents will say that there is a small but real risk of biopsy-related complications that could delay treatment. And important thing, EUS, FNA, and FNB has a very low negative predictive value. Like suppose if you get a negative result, you can never be sure whether you have missed a malignancy, and hence again patient will probably have to undergo a surgery. So this group will say that diagnostic laparoscopy followed by resection is probably a better approach. But then it's a debatable topic. My approach is to obviously acquire a tissue. It gives an added advantage of confirming the malignancy, and sometimes you can get a surprise like autoimmune pancreatitis or tuberculosis. If the first approach is negative, it had been an aspiration, I'll repeat a core biopsy. But if it is negative second time, the patient has to undergo surgery. So you should remember that surgery is also a part of a diagnostic armamentarium. So again, I come back to the differential diagnosis. By following this approach, most of the disease can be diagnosed, but we are left with 3 important entities which closely mimic each other: adenocarcinoma, inflammatory mass, and autoimmune pancreatitis. These are very, very difficult to differentiate. There are some improvement in our diagnostic capabilities. There is availability of elastography, which can help in differentiating inflammatory mass from adenocarcinoma. Adenocarcinomas are usually more stiffer, so they will give a blue color on elastography, whereas inflammatory mass will have a variable pattern, predominantly soft pattern, so they will have less of blue and more of green. And this can be complemented with a contrast enhanced EUS, where you can see that the mass is stiff on elasto, and on a contrast, it is hypo-enhancing. But again, it is not 100% specific. You will still miss. So at best, these are add-on investigations, which probably, you just put them on balance and see on which side they are adding on to find whether it is a malignancy or a benign condition. Then now we have FNB. We know that FNB has improved the diagnostic accuracy of pancreatic cancer. And similarly, for diagnosis of AIP, we need 3 or 4 criteria to be present on histopathology. And unfortunately, on FNA, we can only assess 1 criteria, that is IgG4 cells. So the studies have shown that FNB has improved our diagnostic capability for diagnosing AIP, but this is not the case always. And finally, inflammatory mass, a confident non-surgical diagnosis is still a major concern. So despite all these efforts, you may still not get a diagnosis. For example, in this case, you can see there is a clear mass in the uncinate process. Patient has come with abdominal pain. There is no jaundice. CA19-9 is elevated. The IgG4 is normal. You see a clear hypoechoic mass in the head of pancreas. It is stiff on elastography, suggestive of adenocarcinoma. You go ahead, do an FNA, you don't find any malignant cells. Second time, you go ahead, do a fine needle biopsy, EUS elastography guided. There you look at the sampling of the hard lesions. Again, you don't get a diagnosis. So this patient is sent for surgical resection, and finally we get a diagnosis of type 2 autoimmune pancreatitis. So you should be prepared for surprises. You cannot always get diagnosis. So to sum up, what are the learning points for solid SOL? CT with pancreas protocol and EUS, FNA or FNB are helpful in establishing diagnosis in majority of patients. If patient is a good surgical candidate, the clinical presentations like pain and jaundice and imaging is typical for a resectable cancer, you may proceed without a tissue diagnosis. It's not a wrong approach, but biopsy is clearly indicated when there is diagnosis is unclear or patient has got a suspected cancer, you want to give chemo or neoadjuvant. And then negative biopsy in a patient with suspicious pancreatic mass that is resectable, a surgical exploration should be done in these patients to establish the diagnosis and treat the disease. So I think this is all for solid SOLs. As per the format, we are just going to break for a few questions before I take up the cystic SOL. So I hand over back to the moderators.
Right. So I think well covered so far, Dr. Surinder. We have only a few questions that have come in, and we're trying to take them one by one. One is regarding the CA19-9 as a marker, and there's the question Dr. Shinde from Hyderabad wants to know, why is CA19-9 increased in patients with biliary obstruction?
You know, CA19-9 is a marker which is secreted from the cuboidal cells. So whenever there is a biliary obstruction, there is reflux excretion of this enzyme into this marker into the bloodstream. So that's why whenever there is an obstructive jaundice, the CA19-9 gets elevated. Hence, it's not a very specific marker for diagnosis of pancreatic malignancy or any malignancy from that area.
Right. And is there any particular cutoff, Dr. Vinila Jose from Jose wants to know from Tiruvilla, a particular cutoff that can help us differentiate between biliary obstruction, malignancy, or other false positive elevations of CA19?
Yeah, there are few studies which have looked at if there is any cutoff which can clearly differentiate with a high positive predictive and negative predictive value, but unfortunately there is no such value which can differentiate whether a biliary obstruction is causing CA19 elevation or not. The best approach in such situation probably would be to drain it and see what happens to CA19 levels.
Right. Okay. And I think the other questions are related to concerns about seeding of the needle track. Dr. Karthik from Chennai has a question that there is a Japanese study reporting seeding of the needle track following US aspiration, following US. So what you mentioned something about that in your talk. What are your thoughts? I mean, how important is it? Does it happen, and how important is it?
Yeah, EUS guided FNA needle tract seeding. If you look at literature, there are only few reports, that too from the mass lesion you have aspirated from the tail. If you are aspirating it from head area, in any case, that area is going to be taken out. So the needle tract seeding is not a concern for a head mass, but for body and tail, yes, there are reports. But then as compared to percutaneous FNAC, the reported incidence of frequency is very, very low.
Right. And resectability on EUS, are you in a position to comment? Dr. Anand Chennai question is, unresectable carcinoma of pancreas, can it be, when do you call it unresectable on endoscopic ultrasound?
I deliberately didn't cover that topic because of lack of time, but on endoscopic ultrasound, we can very clearly look at the venous involvement. Venous involvement per se doesn't make it resectable, but on EUS, we can look at the extent of venous involvement, whether the first offshoot of the superior mesenteric vein is involved or not, whether the involvement is going close to the liver. So these things can help in deciding resectability or unresectability on EUS. For arterial involvement, obviously MDCT is better than EUS.
Okay. Differentiation between chronic pancreatitis and pancreatic cancer on EUS, particularly since imaging characteristics are similar. This is Dr. Vineet Kumar Tomar and a couple of other people. Uncinate process, acute inflammatory mass vis-a-vis head of pancreas, malignancy on endoscopic ultrasound. What would you say?
Yeah, I think as I've highlighted in my talk, it is one of the most difficult tasks we face to differentiate between inflammatory mass and pancreatic malignancy. Despite the best efforts, we still may not be able to do it. But on EUS, we look for whether if you are able to see small fluid collections inside the mass lesion, that would suggest an inflammatory mass. If you are doing an elastography, if it is not very stiff, variable stiffness, it's an inflammatory mass. And on contrast, it is showing some patchy enhancement, then again it's an inflammatory mass. So these are the three features which will give you a confidence that probably it's an inflammatory mass. But again, you just cannot exclude a malignancy, small malignancy sitting inside an inflammatory mass. So one has to decide the treatment approach depending upon the patient's symptoms and the imaging modalities, the results of which you have obtained.
Okay. So I think there are a few questions related to cystic lesions, which I'm not taking up.
Take it up.
That we can talk about is a differential diagnosis for hyperenhancing lesion apart from NET. Is there any such on CT scan?
For NET,
differential diagnosis for a hyperenhancing lesion apart from neuroendocrine tumor.
You know, NET is the most common lesion which hyperenhances, but then certain metastases like renal cell carcinoma, even melanoma to pancreas are known to hyperenhance. And similarly, lymphomas also hyperenhance, but they have a patchy enhancement. But neuroendocrine tumors will have a characteristic enhancement in the early arterial phase. So if you have an enhancement in an early arterial phase, the two differentials which I'll keep is NET almost 90% times. If a patient has a history of renal cell carcinoma, then 10% of times will have a renal cell carcinoma, almost closely mimicking a neuroendocrine tumor.
Last question in this segment before we move on to the rest of your talk, Surinder, is from Dr. Lawrence Peter in Bangalore. His question is it possible to make a diagnosis of type 2 autoimmune pancreatitis without resection and histopathology, only on imaging?
I think it's impossible. On imaging, you just cannot diagnose type. Even after doing a biopsy, you cannot. Our experiences of 3 patients, and all 3 patients have been diagnosed on resection only, despite we haven't done biopsy, FNB also in them. So I think it's difficult to diagnose on imaging.
Right. I think there are a few more questions which we can take up at the end. Maybe you could proceed with the talk, and we'll come back to solid if there is time at the end.
Okay.
Thank you.
So having covered the first part, the second part is cystic SOL. It's a more difficult diagnostic dilemma because majority of these patients are asymptomatic and you're going to have an incidental diagnosis on cross-sectional imaging. So it is very important to accurately characterize. You don't want to offer a morbid resection for a relatively benign disease, and you should not be missing a potentially malignant disease. So it becomes a much more difficult exercise. And if we look at the literature, we have many guidelines, but we still don't know which is the best, which one to follow. Now let's look at the pancreatic cyst. There is a huge list, but basically it is epithelial and non-epithelial, and then we classify as neoplastic and non-neoplastic. But majority of our exercise is to differentiate between the various neoplastic pancreatic cystic lesions. Now let's look at the spectrum of cystic lesions. Despite having such a big list, majority of them, almost half of them, will either be intraductal papillary mucinous neoplasia, that is IPMN, or a mucinous cystic neoplasms. And rarely you can have a ductal adenocarcinomas, endocrine tumors, and SPEN presenting as cystic tumors. So here again, we need to follow a stepwise diagnostic approach. The first step is to differentiate between a pancreatic cystic neoplasia and a pseudocyst, which is most of the time easy. You can have an elevated amylase lipase, telltale signs of pancreatitis. So I'm not going to discuss about that. The second step is to differentiate serous versus the rest. And finally is to accurately diagnose mucinous versus rest. And here comes the problem where you want to differentiate benign versus potentially malignant. So short of histopathology of the resected specimen, you just cannot do that. So what you do is you try to characterize them as MCNN, main duct IPMN, mixed type IPMN, branch duct IPMN, and then offer treatment depending upon their natural history. And then also it is very, very important to remember that when you are evaluating a patient with cystic neoplasm, you should always be aware that there should not be any pancreatic adenocarcinoma sitting elsewhere, which is quite common in patients with IPMN. Now let's look at the blood markers. Again, like a solid SOL, even in cystic SOL, there is no DNA, RNA, or protein biomarker in blood which can differentiate various cyst types or identify the high risk. I have talked about amylase lipase, their role in differentiating pseudocysts from other PCLs. And then again, CA19-9, as in solid, similarly in cystic SOL, they don't have any role in screening However, in subset of patients with diagnosed IPMN, you can use it as a marker for malignant transformation or a coexisting adenocarcinoma. Now, cross-sectional imaging, unlike a solid SOL, CT abdomen has a very limited role in a cystic SOL. You can maximum detect calcification, which can help you in diagnosing mucinous cyst, but CT is a very poor modality for evaluating the detailed morphology of the cyst. And then you can obviously not comment on the ductal communication, which is one of the important markers for differentiating IPMN with mucinous tumors. Then PET-CT, again, there are very few studies, but whatever they have evaluated, very limited role. False positives and false negatives we know, and FDG avidity in a frankly malignant cyst is very rarely encountered. And whenever you have a cystic lesion where FDG is avid, you can easily diagnose it as a malignant cyst even on a CT scan. So FDG PET is not usually useful in pancreatic cystic lesion. So the cross-sectional imaging here, which is useful in cystic lesions, is MR of the abdomen, because it can give you a detailed morphological evaluation where you can easily identify a serous cyst adenoma, wide characteristic microcystic spaces, and a central scar. A relationship with pancreatic duct can be evaluated. However, again, MR is not going to tell you differentiating between benign and malignant cysts, as well as mucinous and non-mucinous cysts. So what do you do at second step? MR, you do an MR. MR is going to show you a microcystic morphology. You can diagnose it as a serous tumor, serous cystadenoma, and the rest will come into a different category. And then it will also tell you whether there is any coexisting mass lesion anywhere else in the pancreas. It can document relationship of pancreatic duct with the cyst. And therefore, all patients with a cystic space occupying lesion of pancreas should undergo MR and MRCP. So once we have done MR, now we've reached the most important and a difficult third step, which is a diagnostic conundrum, where we want to differentiate mucinous versus rest, benign versus malignant, mucinous, main duct, mixed type, branch duct, and then finally cystic solid tumors like NET and SPEN. So here the problem is you need to just give a pause and see whether you need to evaluate these patients further or not. If patients are symptomatic and the symptoms are explained cyst, that means you have pressure symptoms, then obviously you have to offer surgery to these patients. And if patient is asymptomatic, there is no need for further evaluation. If MR clearly shows a morphology of serous cystadenoma, or if your patient is unfit for a resective surgery, there is no point evaluating further. But if these conditions are not met, then this will require further evaluation. And then how do you evaluate further? In such situation, EUS is an ideal tool for evaluating the cystic lesions. Because of high resolution images, you can evaluate the morphology of the cyst much better. You can clearly see the nodules and septae. You can clearly document the relationship of the cyst with pancreatic duct. And importantly, there is no influence of the gas in the bowel loops on acquiring the EUS images. Like for example, this is a classical appearances for serous cystadenoma. You will have microcystic spaces, central echogenicity. Nothing more evaluation is needed. If patient is asymptomatic, just follow up the patient. Similarly, SPENs will have mixed echogenic areas, hyper, and anechoic areas, which can help you in diagnosing SPEN. And then you can easily see a mural nodule on EUS. And then if you do a contrast, you can find it enhancing. So this again is helped on EUS. But then we have to understand EUS again is not a panacea. It is confounded by subjectivity of interpretation. Predicting malignancy in MCN and IPMN is very, very difficult just based on EUS imaging. So EUS finding at best may add some diagnostic information, and you have to proceed forward. The step forward is to do a cytological, chemical, and genetic analysis of the cyst fluid using an EUS guided FNA. But then EUS FNA is not to be done in all cystic lesions. A cystic lesion of 1 centimeter asymptomatic, you just don't need to do an EUS FNA. It is usually done in cystic lesions which are more than 3 centimeters in size, or they have a mural nodule where you sample both the fluid as well as the mural nodule. So what do you do when you aspirate? The first step at bedside is to do a string sign, where you just take a drop of the fluid between your thumb and index finger, between ring finger and thumb, and then just stretch it. If the string is formed of at least 1 centimeter in length and it lasts for 1 second, that suggests it's a mucinous tumor. And then you send the fluid for cytology on slides. You send for biochemical markers like amylase, lipase, and triglycerides. You can have a surprise of lymphangioma or pseudocysts still despite all the imaging. So you need to send these biochemical markers. You send tumor markers, which include CEA, CA99, and VGF, and then you do molecular markers. Of all these markers, the most important is cystic fluid CEA. The pooled sensitivity is about 63% and specificity is 93% when we take a cutoff of 192 nanogram per ml for CEA. So it is very helpful in differentiating mucinous versus non-mucinous. And CEA less than 5, CA 19.9 less than 37 excludes a mucinous cyst. So it will give you a little added confidence. And importantly, CEA level is not predictive of malignancy. Like CA is 10,000, it doesn't mean that it's a malignant mucinous cyst. And VEGF is a very specific marker for serious cyst adenoma, which usually you will not require because you will be very comfortably and confidently able to diagnose cyst adenoma on EUS and MRI. Now, what about cytology? It has got a very high specificity. If you see malignant cells, it means it's a malignant cyst, but then it has got a very low sensitivity, less than 10%. So you are not going to pick up all the mucinous or malignant cysts. Then molecular markers, there is a lot of talk, a lot of literature of late on various molecular markers like KRAS, GNAS, RNF43, and then they do a next generation sequencing using combination of markers. But again, the results are not so encouraging. KRAS mutation is usually found in mucinous cysts like MCN and IPMN. If GNAS is positive, it is fairly good specific marker for IPMN. The studies which we have done in our center, we haven't found GNAS positivity in IPMN in our country. So we need to evaluate it further. So, and importantly, KRAS and GNAS are not able to differentiate between benign and malignant cysts. So the studies which have been done comparing molecular markers with imaging and CA, they have realized that the markers have the same diagnostic ability as CA. So what we get with an EUS-FNA is better differentiation between mucinous and non-mucinous cysts by doing a CEA levels. And then we can diagnose a main duct IPMN by looking at the duct morphology and a solid lesion inside the duct. And we can easily diagnose a solid cystic SOL, as I had showed you in one of the images earlier. But then the problem is, even after an FNA, the differentiation of a branch duct IPMN from a mucinous tumor is not possible. And then you cannot differentiate between benign and malignant. So hence, there are a lot of efforts to develop neural tools. Contrast EUS, where you look at the enhancement of the mural nodule. If it has got a patchy enhancement, it is fairly specific marker for malignant or a potentially malignant cyst. But again, it is not 100% specific. Then there are EUS through the needle cystoscopy and confocal laser endomicroscopy. The initial results were encouraging, but it's a very costly equipment. And then again, the results of the subsequent studies are not so encouraging. And then off late, this is the through the needle microbiopsies forceps, which are more forceps, where you just try to acquire the biopsy from the cyst wall. Again, the results are encouraging, but you don't get a diagnosis in all the cases. So after having understood the limitation of all the imaging modalities we have for cystic lesions, at present, what we best can do is do a combination of clinical and imaging findings and then have a treatment algorithm. So if you, what you should look for in a cystic lesion is patient having jaundice secondary to the cyst? Is patient having recurrent episodes of pancreatitis due to cyst? Is CA 19.9 elevated? Is there a mural nodule? And if yes, is it enhancing? What's the enhancement pattern? Is it patchy or diffuse? Is the duct more than 5 millimeter? Is there is an abrupt change in main pancreatic duct caliber with upstream parenchymal atrophy? Is the size of cyst more than 3 centimeter? And then if you have a follow-up imaging, is there is increase in cyst size of more than 3 millimeter per year? And on cytology, do you have a high-grade dysplasia or malignant cells? So in nutshell, all these are worrisome features which suggest that you should be offering a resectable treatment, resective surgery to the patient with these features. So what's the treatment algorithm we follow is that if you look at cyst on imaging, if the radiographic features on MR are classical of a non-neoplastic cyst or serous cyst adenoma, no further evaluation is needed unless the patient is symptomatic, or if patient is unfit for surgery, you don't need to proceed further. On the other hand, if these features are not present, then you look for obstructive jaundice, you look for mural nodule, you look for duct, if duct is more than 10 millimeter, and if cyst is causing pancreatitis, then this patient requires surgery. Some surgeons may like to do an FNA, but I think there is no point doing an FNA. Surgery in a fit candidate is the right approach in this group of patients. If these features are not present, then you look for the duct diameter. Is it between 5 to 10? Is the cyst more than 3? And if you have a change in main duct caliber, if these features are present, then you do an EUS. You look at the duct. You try to find if there is any polypoidal mass in the duct. If you are seeing a cyst, you look whether there is any mural nodule. If there is an abrupt change in caliber, you see whether there is any mass or not, and then you do an FNA. If there is a main duct involvement in the form of mass, if the cytology is positive, and if the mural nodule is enhancing, then this subgroup of patients should undergo surgery. And if this is not present, then you repeat an MRI after 6 months to see the change in the size of cyst. If the cyst is not increasing in size and patient remains asymptomatic, you can put the patient on surveillance. If, on the other hand, if these features are not present, you look at the size of the largest cyst. If it is less than 1 centimeter, you can just relax for 2 years, repeat an MR after 2 years to see for any increase, the criteria which I have mentioned earlier. If the size is between 1 to 2 centimeter, you do MR after 1 year, again look for change in size. And if the size is between 2 to 3 centimeter, how confident you are that it is clearly IPMN or MCN. That means that you should not be missing a cystic NET or a cystic SPEN. So if this thing is present, then you do an EUSFNA. If you're clear that is IPMN or MCN, then you do MRI 6 to 12 months later again to look for the change in the size. But then despite all these flow charts and all these investigations, how correct we are. This was a study published in Pancreatology in 2018, where despite following all these protocols, 1/3 of the resected cysts did not conform to the preoperative diagnosis. There were considerable number of benign cysts which were inappropriately resected. Not even combination of 2 or more different imaging techniques correlate with better preoperative characterization. And inappropriate resections of benign cystic lesions is significantly higher in patients who had a preoperative diagnosis of presumed MCNN. So in a nutshell, we still need a lot of improvement in our capability to accurately characterize preoperatively the cystic lesions. But till that time, we need to follow this protocol, which I've just discussed. So the learning points for cystic SOL are: EUS is an important diagnostic modality for evaluation of pancreatic cystic lesions. EUS without FNA will give only limited information. Molecular markers at present are just coming in. They probably hold a considerable promise, but we need to pick up much better markers which have a good discriminating value. Hence, the diagnostic approach is still evolving. We don't know which is the correct approach. And in this situation, we desperately need newer technologies for accurate preoperative diagnosis. So that's the last slide of mine, and I close my presentation and hand over to the moderators.
Thank you, Surinder. Thank you very much for such a wonderful talk on this topic. And we have many questions. So maybe we ask Dipto Chaudhary to take you through some of the questions.
Yeah, there are more questions than the time would permit. Just a few questions, which some of the questions that came through. Some of the questions are from the previous sessions, of course, but some which are pertinent to this particular session. I'll just go briefly to this one. Is that number one question that came in from this one is that since Dr. Surinder, there's some questions have been on the guidelines that we follow. Which is the particular guideline to follow? There have been the ACG guidelines and the ZIM guidelines. Which guidelines should someone follow as regards the follow-up is concerned?
That's why I told it's, all the guidelines, they have some advantages, some disadvantages. So what I did was to pick up the combination of all those 4 guidelines and the approach which we follow in PGI. That's what I have presented. So this is the crux of all the 4 guidelines which are available.
And is there a role for pancreatoscopy or spyglass in the diagnosis of cystic lesions of pancreas, especially IPMN?
I think it's a very good question. Pancreatoscopy is quite helpful in patients with main duct IPMN, where you can go inside, sample the pancreatic juice, look for cells. You can even biopsy the pancreatic duct and look for IPMN. But then there is no head-to-head study which has compared pancreatoscopy with a properly done EUS. But then obviously once you are going inside and directly sampling, it will obviously have a better specificity. So, pancreatoscopy and intraductal ultrasound are other imaging modalities which can probably help in better preoperative characterization of main duct IPMN, especially in patients who are borderline risk for surgery. Like suppose if a patient is a good candidate for surgery, you see a polypoidal lesion in the duct is more than 10 millimeter, you probably go ahead with surgery rather than subjecting patients to these investigations which carry a risk of post-ERCP pancreatitis.
When you are, this is a question from Dr. Aditya Kale from Mumbai. What is your choice of needle when you're doing an FNAC of a lesion, a cystic lesion?
Yeah, again, it's a very, very important question. When we do FNA of cystic lesions, we are not sure whether it's a mucinous or non-mucinous. So it's always better to go ahead with a 19 gauge needle because you want to completely aspirate the cyst. If you're not able to aspirate the cyst, then you will obviously lead on to infection. But doing a FNA from the head or uncinate with a 19 gauge needle is difficult. So what I do is head, body, tail, I'll prefer a 19 gauge. But if I have to sample a uncinate process, I'll go ahead with a 22 gauge needle unless and until cyst is very big, where I doubt with a 22 gauge needle, I'll be able to completely aspirate the cyst.
There's been another question, probably related to the pancreatic as well, which we have not addressed, is the role of liquid biopsy.
Yeah, I didn't talk that because it's beyond the diagnostic approach, because there are various other ways of cytological diagnosis. You can do cell block, you can do a liquid biopsy, you can do a frozen. So a lot of things are there which I didn't cover. So this is beyond the domain of this lecture.
Beyond the realm. So there will be some questions on that. We'll avoid this.
Sudipto, can I ask another question? There are many questions coming on the differentiation of inflammatory mass and pancreatic cancer. And at least 3-4 persons have asked about this question. And I also believe that we also face this problem many times, how to differentiate inflammatory versus mitotic mass in head of pancreas. Sundar?
Yeah, this is for me, yeah. Okay, so inflammatory mass for you to Surinder. Inflammatory mass versus adenocarcinoma, I must admit, it's a very, very difficult dilemma. Even the best pancreatologists sometimes will not be able to differentiate. So what you need to do is you need to first look at the patient's symptoms. If there is a head mass in chronic pancreatitis patient is having an intractable pain, there is no point differentiating and doing an EUS, whether it's a malignancy or inflammatory, because in any case, patient will probably require a Whipple. So in that situation, there is no point differentiating. But then if surgery is not an option, you can manage patient non-surgically with a mass lesion, then you probably have to do an EUS. If you have an elasto, you do an elasto, you do a contrast. And I follow up a protocol of at least doing twice an FNA so that we are sure that we are not missing a malignancy. And then importantly, keeping this patient on follow-up. Do a follow-up imaging 2 months or 3 months later to see whether there is any discernible size change in the size.
In continuation with this, Surinder, we could just ask you, there's an interesting question about a patient with a small tumor presenting with acute pancreatitis and pancreatic inflammation.
Yeah.
How would be your approach on EUS or otherwise? And how would you go about sampling and establishing the distribution of pancreatitis?
Very, very important question, because small pancreatic SOLs, whether it's an IPMN or an adenocarcinoma, can present as pancreatitis. So that's why classical teaching is whenever any patient is above 40 years of age with unexplainable pancreatitis, you should always keep a possibility of a pancreatic SOL in them. So in any case, in idiopathic pancreatitis, EUS is a part of protocol. But the EUS is done only after 4 weeks once inflammation is settled, and there are various pros and cons of doing an EUS at 4 weeks or early EUS. But then if you have done a proper CT scan, mass lesions would usually be picked. Only small, say less than 1 centimeter mass lesion may be missed on initial CT. Then when you do an EUS, you probably will be able to pick up the mass lesion. So the correct approach is to do an EUS at least minimum after 4 weeks. You should not be going later also, because later the lesion may increase. You will lose that window of resectability.
So,
Dr. Surinder, if I understand, you said that when you repeat it, going back to the same point again, when you have a mass lesion and you repeat the FNAC, you do it with an FNAB needle.
Yeah, what happens for last 1 year, we have switched completely to FNB, because FNB has got a better diagnostic accuracy as compared to FNA, especially for desmoplastic lesions. Like for adenocarcinomas, FNB is definitely better than FNA. So, if the resources are not a constraint, you should probably go ahead and do an FNB and do a proper sampling, and handling the sample is also important, which maybe can be covered in subsequent lectures, how to handle the samples which have been aspirated.
There's been a lot of questions on this needle track feeding. I think people are concerned about the tail lesions particularly. I think there's a question from Bangladesh also about needle track feeding in patients with tail lesions. So what about,
the needle tract seedling is more
especially
hyped,
for
I
tail
think.
lesion?
Yeah, it is more hyped. That's what I think. We have been doing EUS FNA. You also must be doing. It is very rarely encountered. Theoretically, yes, from a tail lesion, if you do an FNA, there is possibility of a needle tract seedling. But if you look at literature, there is hardly 1 or 2 cases reported. And if your imaging diagnosis clearly fits into an adenocarcinoma and your surgeon is confident enough of going ahead with a resection without tissue diagnosis, you can go ahead. So there is no harm in that. So ultimately, it has to be tailored to patient's clinical condition and your surgeon's preference.
I think I'll just jump in there. There's a very interesting question from Dr. Ghosh in Dhaka and Dr. Shine in Calicut. In a patient where the differential diagnosis is between autoimmune pancreatitis and adenocarcinoma and attempts at endosono and others have been negative, is there a role for a therapeutic trial of corticosteroids? People seem to think that might help them. What do you think?
I think in this situation, before going ahead with a therapeutic trial, PET-CT would be a useful modality, because PET-CT in type 1 autoimmune pancreatitis will show you uptake in either kidneys or salivary glands. So that may help you in differential diagnosis, but then you have to look at the clinical scenario. You have to explain to the patient that it still can be malignancy, because you don't want to end up in a situation where you give steroid and you convert a resectable into an unresectable malignancy, and then patient is going to sue you. So you have to look at the size of the lesion, carefully look at the other clinical parameters, maybe CA19-9 levels, IgG4 levels may be helpful, the morphology on US may be helpful, but again, the decision has to be individualized. In our practice, majority of time when we have done this, 80 to 20 would be adenocarcinoma. So 80% of times it still will be adenocarcinoma. So it's only 20% where your therapeutic trial is going to be successful.
Deepto, you must have questions on your list.
Yes, I'm just going through the same list only. There's one more question which came into this again, is that going back to, this is from Lucknow. If a patient having a pancreatic cyst with another cystic lesion, how do you suspect a patient to have a pancreatic hydatid? Now, I have never come across a pancreatic hydatid ever. Dr. Surinder, should it be aspirated? That's the question.
We have seen 4 patients with pancreatic hydatid. Luckily, they have a classical appearance on EUS. You will find daughter cysts, you will find scolices with echogenic debris. So you can easily differentiate. So whenever you do an EUS, you find those daughter cysts, you don't aspirate, you do an MR. MR will also have characteristic appearances of those daughter cysts, and then the patient should straight away go ahead for dissection. Hydatid serology is usually helpful, because all these 4 patients which we had seen had positive hydatid serology.
The same goes, there's a very smart question. If somebody has a small SOL in pancreas, would you think of ablating the lesion as you do for liver lesions?
Ablation for pancreatic lesion is still coming up. If it is resectable, patient is fit for surgery, no role for ablation. It is to be done only in patients who are unresectable or unfit for surgery, and it should at present be done as a part of trial. It is not recommended as in a routine clinical practice.
Another nice question was if there's an uncinate mass that is encasing the SMA and SMV and EUS FNA is negative. This is from Dr. Arun Singh in Indore. What should be your next approach? And in continuation, Dr. Rajat from Bhubaneswar wants to know the role of EUS in the diagnosis of groove or management of groove pancreatitis.
Okay, I'll take the first question. If the vessels are involved, that means it's unresectable. So you have to make all attempts to establish a diagnosis. If your FNA is negative, go ahead with an FNB. You probably can do a contrast or elasto to select the area from where you want to sample. If that is also negative, then off late there is a new modality which is coming up, is a PET-CT guided biopsy, where few initial studies have shown that it has got a better yield as compared to CT guided biopsy, because in this situation, you need to establish a diagnosis before offering a therapy. Then second question is about groove pancreatitis. Groove pancreatitis has got very classical features on EUS. Now, there are a lot of papers which have looked at the features of groove pancreatitis. In groove pancreatitis, you will have features resembling pancreatitis, but mainly involved around the groove area, and you will see small fluid collections in the duodenal wall as well as in the pancreatic head area adjacent to the duodenal wall. So I think on EUS, you can make a very confident diagnosis of groove pancreatitis.
There's one other question from Jatin from Delhi. he wants to know from you that should MRI be done in all patients with pancreatic SOL?
As I have mentioned, for solid SOLs, MDCT is probably better than MR because of wider availability and easier interpretation. As I have mentioned, MR is to be done only in situations where there is no clear-cut mass on CT scan. And studies have shown that MR is probably better in picking up peritoneal metastasis and omental metastasis. But again, it's from few studies only. So for a solid SOL, MR has no added advantage. But for a cystic SOL, yes. For all cystic SOLs, MR should be done.
Dr. Abhishek Bhattarai's question from Nepal is interesting. Can PET-CT help us to differentiate between inflammatory and neoplastic mass in a patient with chronic pancreatitis and a mass lesion in the head?
The answer is clear-cut no, because it's going to be positive in both the enhancement the FDG avidity, the SUV value. Nothing helps in differential diagnosis. So that dilemma is always going to remain. Many times we have seen patients who have strongly FDG avid lesion in pancreas. We keep on sampling. We don't find malignancy. We subject them to surgery. It's an inflammatory mass. So it's not going to help.
And the role of diagnostic laparotomy or laparoscopy for patients, well, diagnostic laparoscopy for people with pancreatic SOLs. When, I mean, in this modern era of such extensive imaging we have discussed, when would you consider this option?
It depends whether the patient is with a gastroenterologist or a surgeon. Surgeon will always, if do a CT, find it is resectable, first do a diagnostic lab and then resect it. They will not like to, subject the patient to a wide list of investigations, which we do. But then if patient comes to us, I think EUS is a good modality. If you have done a proper EUS, you can easily pick up peritoneal mets. You can pick up omental mets. You can pick up small liver mets on the left side. So if by and large the tumor is resectable on EUS, there is probably no need for a diagnostic lab staging. You can straight away go ahead with resective surgery. Our experience is that they have hardly found metastasis once we have told them that there is no metastasis.
There's a question from Dr. LVK from Coimbatore. This is regarding neuroendocrine tumors of the pancreas. Should we go ahead with surgery directly, or should they still be FNA? Should go ahead with FNAC?
No, the approach for a neuroendocrine tumor is altogether different. Once you have an enhancement pattern of neuroendocrine tumor, you need to do the tomogran and NSE, and then you need to do a gallium DOTA PET. You want to see a DOTA PET, you want to look for metastasis. If there is no metastasis anywhere else, then you can straight away go ahead with surgery, because the DOTA PET is going to tell you about the enhancement pattern with NET. So it depends upon the surgeon's choice. But by and large, if it's a resectable lesion, classical imaging findings confirmed on DOTA PET, you can probably go ahead with surgery.
Finally, I think Dr. Alok Sehgal from Jalandhar wants to know, is there any role of pre-procedure antibiotics prior to EUS, FNAC, FNAB for pancreatic cystic SOLs?
First I should admit that there are no comparative studies which have looked at antibiotics versus no antibiotics. But then the logic is, whenever you are aspirating a fluid-filled space, you are not sure that you have completely aspirated. So giving an antibiotic is a part of protocol everywhere, and we also give pre-procedural as well as post-procedural oral antibiotics for a total of 5 days.
Right.
The other question, Surinder,
yeah,
is that can we differentiate lymphoma, pancreatic lymphoma and pancreatic carcinoma on EUS? Ultrasonography, can you differentiate pancreatic lymphoma or pancreatic carcinoma?
On EUS, both will have almost similar morphology. Both of them will be hypoechoic. So on EUS, it is not possible. On contrast, the lymphomas will have patchy enhancement, and adenocarcinomas will be hypoenhancing. On elastography, adenocarcinoma will be more stiffer, lymphoma will be less stiffer. This is theoretical. Our experiences, we have not been able to differentiate. We had 3 cases of lymphoma. When we thought it's an adenocarcinoma, it turned out to be lymphoma. And when we thought it was lymphoma, it turned out to be adenocarcinoma. So ultimately, tissue diagnosis is the one which can help. But these are some subtle points which can help in differentiating between the two.
And one other question is from Pradeep from Pondicherry. He wants to know that what is the role of CA 72.4?
In solid or
I've not heard 72.4, but it is a question. Is there a role of CA 72.4?
No, if there are a lot of other CA markers which have been evaluated, not leave alone 72, there are many other which have been evaluated. But then apart from CA99, no other has got a diagnostic role in either a solid or a cystic SOL.
Right. And are there any medical legal issues, any experience with those relating to the dilemma between AIP and pancreatic cancer, and exploring and resecting an autoimmune pancreatitis, or not picking up a pancreatic carcinoma? I think we keep hearing about these. Have you any such experience?
Fortunately, no, but I think it is very important to explain to the patient that, this dilemma is there, this dilemma may remain. The choice has to be left to the patient whether he wants to undergo a surgery or not, because we had few patients, young patients, less than 30 years of age, who had been evaluated extensively at multiple places, even given steroids as a possibility of AIP, and by the time they reach us, it was a metastatic adenocarcinoma.
Metastatic, right. Right, I think Govind, an excellent session. Any more, or I think has Surinder had enough, or you are still game for some more questions?
No, I'm fine, sir. If you want, I can still answer.
Dipto, you want to ask some last questions, sir?
Yeah, no, yeah. So there was this question on someone asking about Dr. Surinder's experience with insulinomas, and Dr. Surinder.
Insulinomas, I think EUS is a very good modality, because we know that insulinomas can be multiple. So you may pick one NET on CT scan or MRI, and EUS will help you in identifying other NETs. So for insulinomas, what we do is we do an EUS, do a proper evaluation of pancreas, and then if it is a very small lesion, it will be very difficult for surgeons to identify. We even do a tattooing with methylene blue so that surgeons can identify it intraoperatively. So EUS is a good modality for insulinomas.
So we can, I think, we can close now. Dr. Surinder, we are happy to tell you that there have been 2,200 people or colleagues logged in, and 1,600 people participated through your talk. And we must tell that this was a masterly talk by you on a topic which is not so easily understood by, I would say, for at least for me, it's hard to understand this topic. And I hope that all of us learned from this your talk on pancreatic SOL.
Thank you so much, sir. And thank you, Vivek, sir, and thank you, Sudipto, for being there. It's always a pleasure being with all of you.
Thank you so much. Thank you so much.
Thank you, Sudipto, for I talked to you only 2 hours back, and you agreed to moderate this session. So wonderful. Thank you so much.
It's an opportunity, sir. It's a learning opportunity for me, sir.
Thank you, Dr. Saraswat, for always supporting this activity of ISG. And you want to say something? Yes, please. Yes, please.
All that I was saying was that Surinder has answered, I think, about 35-40 questions today, but that is just out of a 220 list of questions that you've received. So the non-repetitive ones will land up in your lap so that you can answer to them specifically, and we can email the answers to the question. So I think the IG Secretariat will do that. Just send us your answers in whenever it's comfortable for you. And Govind, probably we can have the link of Surinder's talk posted during maybe sometime in the next 24 hours, so that those who have missed his talk can derive benefit. What do you say?
So we have a few notes to make on this. Last 2 talks by Dr. Garg on acute pancreatitis, and by Dr. Ajay Duseja on non-alcoholic fatty liver disease, and now with a third talk, we are going to post this link on the website in coming days so that you can revisit these talks and get benefit from that. We want to thank Dr. Garg and for sending the questions and responses to many questions which we have posted to everyone. We await a response from Dr. Ajay Duseja, and certainly Dr. Rana will send you the questions so that we get answer on some of the important ones. And this is how we learn from each other. 2 more things I want to say, that since we have a talk of 3 and we have 9 more lined up, we want to know the feedback of all of you, that how has been the experience with the ISG Masterclass. I'm speaking to all those who are participating as an audience to this Masterclass, and we will post probably tomorrow a feedback, which is 1-page feedback, having 7-8 questions. I'm really going to know how was the audio quality, how was the video quality, how were the relay of this. We apologize for today's technical glitch. We missed for 10 minutes, and we heard about something on a TSO by some doctor, a dentist doctor. And also we will like know from you that what's the topic you want to listen in next sessions. We want, as ISG, we want to continue this activity for longer period of time. May not be every week, maybe twice a month, or maybe once a month as a regular activity of ISG Masterclass. And,
right.
we welcome you for the next talk, which is scheduled on 26th of April. That is on Sunday from 12 to 1 o'clock. And this is to be delivered by Dr. D.N. Reddy from Hyderabad. I think everybody knows Dr. Reddy, and we look forward to listen to Dr. Reddy on this Sunday. And he will speak to us on some tips on how to become a good endoscopist. And I think this is a topic which is relevant to all of us, even for senior gastroenterologists and senior endoscopists, that how to improve your technical skill on endoscopy. With this,
before we finally all of us sign off and say bye to all of you, I think last but not the least, the initiative and the effort being put in by Dr. Makharia and the ISG Secretariat is worth applauding. And all of you who are logged in and who are not members of the Indian Society of Gastroenterology, my request to all of you to download the membership forms from the ISG website and consider joining us and become party to this ISG family for not just these, but many more academic topics to come up in the future. Thank you all. I think we'd like to sign off now.
And one more last note that this activity is supported by Sun Pharma, and all these lectures have been supported by Sun Pharma. Thank you very much. Thank you, everyone, and bye-bye. See you on Sunday.
Thank you.
See you on Sunday.
Thank you.